Hi, good evening all. I am Dr. Malaya Mishra, HOD Emergency Department, Yashoda Hospital, Secunderabad. As all of you know, Yashoda Hospital is a leading quaternary care hospitals and integrated healthcare providers in the southern part of India, located in Hyderabad. So, in every Friday, we bring some interesting case to discuss. It is very much relevant to our emergency department. And for today's discussion, it's a very uh, practical based, that is case based management of traumatic brain injury. To discuss further for today's topic, I would like to invite Dr. Madhu Kiran. He has done his MBBS from RIMS Kadapa, DNB Max Super Specialty Hospital Saket, and he has already pursued MBA and completed his MRCM also. Currently working with the hospital Somajigoda branch as a emergency consultant and academic head. So here we like to listen from our Dr. Madhu Kiran. Over to you, Dr. Madhu.
Thank you, sir. Good evening, everyone. So I'm Dr. Madhu. So today my topic is case-based management of traumatic brain injury. So first, I will discuss briefly regarding traumatic brain injury. After that, I have taken 3 scenarios. These are not the real cases, but for the discussion purpose. So my intention is to emphasize some new guidelines. That is the only thing. So for that, I have taken 3 scenarios and I'm discussing on it. And for each scenario, I'm specifically emphasizing one specific thing. So I'll start from now. Okay. So first, traumatic brain injury. So definition: traumatic brain injury is a non-degenerative, non-congenital insult to the brain from an external mechanical force, possibly leading to permanent or temporary impairment of cognitive, physical, psychosocial function with an associated diminished or altered state of consciousness. So pathophysiology. So traumatic brain injury is divided into mainly it is because of primary injury and secondary injury. Primary injury is induced by mechanical force and occurs at the moment of the injury. And secondary injury is it's not mechanical and it is delayed. It happens, it may be superimposed on a primary injury. So primary injury, there are 2 main mechanisms that cause the primary injury. One is the contact as a direct impact, either object striking the head or brain striking in the cranium, or because of the acceleration deceleration. So primary injury due to acceleration deceleration results from the unrestricted movement of the head and results from the unrestricted movement of the head leads to the shear tensile and comprehensive strains. These forces can cause intracranial hematoma or diffuse axonal injury. So intracranial hematoma is the most common cause of death and clinical deterioration after TBI. Hematomas may be epidural hematoma or subdural or subarachnoid hematomas. So epidural hematoma caused by the fracture of the temporal bone and rupture of middle meningeal artery. So clotted blood collects between the bone and dura. It can grow quickly, creating pressure against the brain tissue. Next one is the SDH. So usually caused by the rupture of the bridging vein in the subdural space. So they can grow large enough to act as a Mars lesion and they are associated with the high morbidity and mortality rates. And next one is the subarachnoid hematomas. Results from the damage to the blood vessels in the posterior fossa stalk. Next entity is the diffuse axonal injury. So it is one of the most common and important pathological feature of traumatic brain injury. So it consists mainly microscopic damage. So and most of the times it is not visible in the imaging. So clinically we have to assess. The main mechanical force that causes the diffuse axonal injury is rotational acceleration of the brain, resulting in the unrestricted head movement. See, rotational acceleration produces shearing and tensile forces, and axons can be pulled upward at the microscopic level. So the microscopic evaluation of the brain tissue often of axons is thought to damage the axonal cytoskeleton and therefore disrupt the normal neuronal function. So next is the secondary injury. Secondary injury, it may occur hours or even after the days after the traumatic event. It is result from the impairment or local decline in the cerebrospinal fluid after TBI as a result of local edema or hemorrhage or increased ICP. As a result of the inadequate perfusion, cellular ion pump may fail, cause so excessive release of excitatory amino acids such as glutamate, aspartate, and exacerbate the failure of the causing formation, proteolysis, and lipid peroxidation. These factors can ultimately cause neuronal death. So most common causes of the secondary brain injury, so hypotension, hypoxia, hypercarbia, hyperthermia, hyperglycemia, hypoglycemia, hyponatremia, seizures, infection. All these things cause a secondary brain injury. So traumatic brain injury is the leading cause of the death for all age groups and contribute to over 60% of trauma-related deaths. So the primary goal of management in TBI are to minimize cerebral edema and intracranial pressure and to optimize cerebral perfusion pressure, thereby decreasing the incidence of secondary injury. So these are the main goals of management of traumatic brain injury. In every case, we'll follow these things. And exceptions, we are discussing case by case. So, with no past medical history brought to mechanism of injuries like roll of a car and patient ejected from the car. So vitals looks normal, temperature 37.5 degrees centigrade and heart rate 76 per minute, blood pressure 90 by 60 and respiratory rate 17 per minute. Initial GCS is 12. So CT head was done showing bifrontal contusion with a skull-based fracture crossing the midline. So 2 hours later to 10. So here, and what additional imaging should you obtain? So just like any other trauma patient, will start with the ABCD approach. First thing what we have to do is, as there is a fall in the GCS, we have to do the reassessment and stabilization of the patient. So given the mechanism of injury, this patient is at definitely the high risk of significant TBI and spinal cord injury and internal trauma. So we'll start with the primary survey. Primary survey, first airway with the C-spine. So we have to make sure that airway should be patent. And in this scenario, GCS of the patient dropped from 12 to 10. So there is a concern for the potential airway compromise and due to the worsening neurological status. And the second thing is patient is agitated. So because of the agitation, ICP may rise and it may further worsen the GCS. So even though GCS is 10, so there is a possibility of further deterioration. Better to consider intubation in this patient. Okay. And along with the cervical spine immobilization. So far, because we have received the patient with a CT scan, so we don't have the images of cervical spine. So until we get the C-spine clearance, we'll secure the C-spine with the C-collar. Next is the breathing. Our goals is adequate respiration and oxygenation. Next, circulation. Circulation, here patient blood pressure is 90 by 60. So given the mechanism of the injury, hypotension may be because of the blood loss or maybe because of the neurogenic shock. So first, we'll give the IV fluids. After IV fluid challenge, if there is no improvement, we'll go for the inotropic support. And if hypotension is because of the blood loss, in that case, we should be ready with the massive transfusion protocol. So anyhow, we'll perform thorough physical examination to identify source of bleeding. Next, neurological evaluation and GCS monitoring. So here we'll look for any lateralizing signs, so which can indicate the site of injury. And next, is there any drop in GCS? Anyhow, we are intubating the patient and we are connecting to the ventilator. So airway and breathing we can attain. And for circulation, we have given IV fluids, and we have started the inotropic support, and we ordered for the blood transfusion. So for that, we have to send the basic investigations and cross matching. So next, after our primary survey, so what are the additional investigations we have to order here? So first thing is like mechanism of injury is very dangerous mechanism. So we'll go with the cervical spine, CT cervical spine, and CT chest, abdomen, and pelvis to rule out other causes of hypertension or pneumothorax, or abdominal injuries or pelvic injuries. So here, the important investigation is the CT venogram. So to see the so this thing we'll discuss later why CT venogram is important in this case. So next, routine laboratory tests, CVP, basic metabolic panel, coagulation profile, blood grouping and cross matching will send. Okay. And next, specific treatments. So specific treatments. So supportive management we have done in the primary survey. In specific treatments, like there is a raised ICP. So we'll go with the mannitol or hypertonic saline. Scenario, considering the low blood pressure, we'll go with the 3% NaCl. And other cerebroprotective measures like elevating the head into 30 degrees and intubation and anyhow permissive hypocapnia. So these things will follow. And next, sedation. So as patient is very agitated, so sedation is also very important. So after intubation and connecting to the mechanical ventilation, proper sedation we have to maintain. So because agitation of the patient, it can further increase the in ICP. Anyhow, try to avoid over sedation as it can further obscure the neurological signs. So the same thing. So here, what specifically we have done? We have done 250 ml of bolus of 3% NaCl. And as patient has a skull base fracture, we have done CT with CT venogram. So why CT venogram? And what kind of imaging we have to select? So here is a small table. So like what studies to based on the clinical scenario. So this case I have included mainly for this. So clinical scenario, concern for the worsening hemorrhage. If we have to see the worsening hemorrhage, the study of choice is the non-contrast head CT. So which is highly sensitive for the acute blood. If the concern is for spontaneous hemorrhage, skull base fracture, cervical spine fracture, or other soft tissue neck injury, clinical concern for brain death. In that case, we'll go with the CT angiogram head and neck. So best evaluation for blunt cerebrovascular injury. Spot sign and leakage sign predict conditional expansion. Can be used as a roughest measure of perfusion, so not diagnostic of the brain death. Next, if there is a skull base fracture, hospital fracture crossing midline, then we will go with the CT venogram. It is indicated to evaluate for venous damage related to skull base fracture, hospital fracture crossing the midline. So here, in this scenario, we have the patient with the skull base fracture and hospital fracture crossing the midline. For this reason, we opted for the CT venogram to see venous damage. So next, negative CT and unexplained persistent neurological impairment. In that case, we'll go for the magnetic resonance imaging. So not typically used in emergency setting, but can be prognostically useful and and depressed mental status out of proportion to the injury. In that case, we'll go for the electroencephalogram to see non-convulsive status epilepticus or subclinical seizures. And next, case number 2. So here, 8 years old man present after fall in the washroom. So here vitals are temperature is normal, heart rate 65 per minute, blood pressure 124 by 69, and respiratory rate 15 per minute, and GCS is 14, E4, V4, and M6. So past medical history is notable for the heart failure, and chronic hyponatremia, atrial fibrillation, and she is on warfarin and dementia. And we have done the CT scan. CT scan reveals 8 mm acute and chronic convex SDH with 2 mm midline shift. So here, my question is whether you go for the to treat elevated ICP or should you give reversal for anticoagulation? What treatment would you prioritize? So just like any other trauma patient, we'll go with the ABCD approach. Here, looks like everything is fine. Patient GCS is fine, vitals are fine. So concern here is like anticoagulation. And next thing, there is a 8 mm SDH is there with 2 mm midline shift, but patient GCS is fine. So even though it is a concern, as GCS is normal, so we can wait as there is no immediate danger of impending herniation. So our first priority here will be reversal of anticoagulation. So here the main thing is like we have to monitor for any neurological deterioration and repeat CT if there is any neurological deterioration. So given her stable vitals, normal respiratory status and mild GCS decline, so you need not to initiate aggressive treatment for elevated ICP here. So however, close monitoring of neurological status and potential for deterioration is critical. Here main thing is the anticoagulation reversal. So here patient is an warfarin for atrial fibrillation and current INR is 2.8. So it's mildly elevated and just within the therapeutic range. And warfarin therapy is contributing to a risk for the bleeding. Here the question is, should warfarin be reversed? Yes. So warfarin reversal is warranted in this case because the patient has the SDH, which is a serious bleed, and any additional anticoagulation could worsen the bleeding. So while INR is 2.8 is not severely elevated, any bleed in the setting of anticoagulation increases the risk of worsening the hemorrhage. So reversal of warfarin should be initiated. So we'll give vitamin K, 10 mg IV, and FFP or prothrombin complex concentrate, which provide the clotting factors and help reverse the anticoagulation more rapidly. So the choice of reversal agent depends on the institutional protocols, but PC is generally preferred over FFP for more rapid reversal in case of acute bleeding. So here a small table regarding the anticoagulation and the reversible agent. So anticoagulation, warfarin. So if patient is on warfarin with IC bleed or a SDH, so the thing is like 4-factor PCC plus vitamin K or fresh frozen plasma plus vitamin K. So we have to use as a reversal agent. If patient is on heparin or low molecular weight heparin, then we will go with the protamine sulfate. If patient is on dabigatran, then we'll go with the idarucizumab or 4-factor PCC or dialysis. If patient is on apixaban or betrixaban, endaxaban or rivaroxaban, then the reversal agent of choice is adnexate alpha and 4-factor prothrombin complex concentrate. And here important thing is the antiplatelets. If patient is an antiplatelets, so there is no evidence to support that platelet transfusion can help. So there is no role of platelet transfusion in these patients. So this scenario I have included mainly to discuss regarding the reversal of anticoagulation. Okay. Next case is case number 3. So here 50 years old woman with no past medical history is found unconscious by EMS after a single car accident without airbag deployment. So here temperature is normal, heart rate 87, blood pressure is 110/70 mmHg, and respiratory rate is 18. So she has no apparent injuries, and her GCS is 13. So she did not remember the accident and what caused it. So how do you approach this patient? So So here, the thing is like mechanism of injury. So single car accident without airbag deployment. It means mechanism of injury is not dangerous. And patient has no past significant co-ops, but she found unconscious by EMS. So approach will be same. We'll start with the ABCD approach. First, airway. So here GCS is 13. So monitor for deterioration. And if as of now there is no need for airway protection. But anyhow, you should be prepared with your crash rally or intubation rally nearby. If there is any deterioration, the GCS or agitation or any vomitings, if there is any signs of rise, then we have to plan for the intubation. And next thing, breathing. So maintain oxygen saturation above 94%. Avoid hyperventilation unless there is a signs of herniation. Next is the circulation. Circulation, we have to maintain the target blood pressure map of around 100 to 110 and systolic blood pressure less than 160. Avoid hypoperfusion and maintain the cerebral perfusion pressure. So disability, we'll check the GCS and lateralizing signs, pupils, GRBS, and if there is any hypoglycemia thing, we'll correct it here. And monitor for the deterioration like vomitings, confusions, and agitation. Next, exposure. Look for the signs of trauma, fever or coagulopathy. So here you can see the CT scan. So there is a subarachnoid hemorrhage. So investigations. So here clearly it is because of subarachnoid hemorrhage. So looks like more of a spontaneous, as the mechanism of injury is not dangerous. So routinely we all take ECG, and protein samples will collect CBP, RFT, LFT, and coagulation profile matching, and CT angiography to locate the aneurysm. As most common cause of SH is a rupture of the aneurysm. So immediate actions, what we will do? First, we'll keep the patient NPO for possible neurosurgical intervention, and we'll get the IV access and we'll connect the contact matter and to anticipate instability. So for continuous monitoring. Next, control blood pressure to reduce the risk of rebleed. Next thing is the start nimodipine, 60 mg 4th hourly to prevent the vasospasm. And next is the seizure prophylaxis. For cortical ACR witness seizures, we'll go with the seizure prophylaxis. Next, analgesia to avoid BP surge from the pain, and antiemetics to prevent vomiting and the raised ICP. So these are the management principles for SH. So here main thing is like most of the people they may mislead because of the trauma. Patient become unresponsive, and because of that GCS has dropped. But most probably the thing what might have happened, patient has SH, after that patient become unresponsiveness, and after then she accident happened. So next disposition is we admit to the neuro ICU, and we'll continue neuro checks, and we'll monitor for the deterioration, and family communication and consent for possible intervention. We have to explain to the patient and patient attenders. So here, teaching parallel is the trauma after spontaneous SH, which can be the mislead initial diagnosis. If trauma seems out of proportion to the event, low speed crash, no airbags, no injuries with confusion or amnesia, always consider primary neurological cause of trauma. So these are the 3 cases. Everything is clear. Any questions?
Any questions from the audience? Dr. Madhu has clearly explained regarding this traumatic brain injury, what we are seeing in everyday basis in our emergency room. We could ask some more questions to him so that he can elaborate a little better. He can enlighten us what is a management protocol, how it should be done. Yeah, Dr. Madhu, I have certain questions, few questions for you.
Yes, sir.
So can you just guide us, like, what is more sensitive test for detecting diffuse axonal injury? Is it a CT scan or a MRI?
Sir, in case like cerebral edema, MRI is a better thing. But in case patient with the diffuse axonal injury, most of the times they are unstable. So for timing, we can go with the CT scan. And if patient hemodynamics
Stable, then we can always.
hemodynamics are stable and if permits, then we can go for the MRI.
Yeah, MRI is eventually better for detecting, is more
Yeah,
sensitive
more
for
sensitive,
detecting
sir. And if
diffuse
you go with
axonal
the
injuries.
MRI brain with the angio, then we'll get even
Yes,
better pictures.
better ideas. Yes. All right. So, second questions I just want to highlight here is, what about this pupillary asymmetry in a traumatic brain injury patients? What does it suggest?
Yes.
Like anything changes in the pupillary size by looking at the initial evaluations from the emergency room? What a emergency physician's perspective, initial management, what the case is leading, and what are the suspicions they should think about it?
So mainly pupillary anisocoria, we have to suspect for the brainstem herniation.
Yes.
So maybe because of the riser ICP, if anisocoria is there, then already herniation happened. So we have to aggressively manage the ICP.
Yeah, all right. But basically, transtentorial herniations or uncle herniations, basically, you should be focus more when there
Yes,
is an
sir.
unequal anisocoria pupils. So, third
Yes, sir.
questions, what I would like to ask is, can you just elaborate on the Monroe-Kille doctrine, that hypothesis? What does it basically suggest?
So Monroe-Kille doctrine hypothesis, it's like the space in the skull is fixed. So if there is anything, if there like if there is any extra thing like any mass or any hemorrhage, so there is no space to expand. So because of that, the brain tissue will be compressed and it is the main cause for the raised ICP. So
Yes,
it mainly explains why the brain herniates and why there is a raised ICP, because there is no space to extend. The
expand.
skull is a fixed bone, so
Yes,
there is no space for the brain to expand. So and there is actually there are some biomarkers. This thing I want to just to add as we have time. So there's a glial fibrillary acidic protein, GFAP,
yes,
and
yes,
ubiquitin carbohydroxylase. So these things, they will like after damage of neurons. So these these are the markers we can detect from the blood. So these are more specific for the intracranial hemorrhage or damage. So these things, it has very high negative predictive value.
yes,
So we can use to rule out the head injury, or in case if you have the mass casualties. So there are so many patients, which patients you have to send to the CT scan first. In that case also, we can use it as a tracing tool. So after 1 hour, it start appearing in the blood up to 12 hours. So what we can do, because this is not available in India, but this will be very helpful in tracing of patient as well as to rule out. In tracing of patient, like we can send this sample, like if injury is after 1 hour. If sample is negative, definitely there is no intracranial injury. So these patients, they can wait for the CT scan. If it is
okay,
there, then there is a possibility of IC bleed. So we can send the patient to the CT scan. So one role is the tracing purpose, and second role is like for safe discharge. In case we have done the CT scan, and if still we have some doubt, anyhow, CT is a gold standard. We'll still follow the
non-contrast
CT
CT,
scan only.
yes, non-contrast
So if
CT
we have
scan.
still some doubt, then we can, yeah, non-contrast CT scan. So if you still have some doubt, in that case also, we can send this investigation. If it is negative, we can safely discharge the patient with the anyhow will discharge the patient with the head injury protocol by explaining all the risks and when to come back, all these things.
All right.
So
All right.
maybe this may be helpful.
Okay. All right. So there is a question in the chat box.
Okay.
There's a 5-year-old boy fell from the staircase
Okay, so 1 minute.
and he lost his consciousness for 2 minutes. At present, the boy is alert and playing. There is no vomiting, no seizure episodes post-event. GCS is 15. Vitals are stable, no focal neurological deficits. Now the question is, does this child require a CT scan? Why, if it is so, and why not? Second question is, what are the Pecan criteria for CT decisions in pediatric traumatic brain injuries?
Sorry, sir.
Like, first question is like,
second
does this child require a CT scan because he fell from the staircase and lost consciousness for 2 minutes? At present, the boy is playing, he's alert. There's no vomiting, there is no seizure. GCS is 15 out of 15. Vital stable, no focal neurological deficit. Only there is a scalp edema.
So actually, as patient, as baby is active and GCS is normal and he is actively playing, so no need of a CT scan as of now. So if in case if we receive that patient in here, so we can to the parents of the patients. So regarding the uh, risk of raised ICP like recurrent vomitings or falling GCS or irritability, excessive crying. So with this we can discharge the patient. So in children usually the sutures are not closed completely. So there is not there is a like it will take some time for them to develop the raised ICP. So here doctor management is not applicable.
Yes.
In this patient. So they will give some time. So the thing is like main thing here is we have to assure the parents. We have to assure the parents and we can safely discharge this patient with a head injury protocol.
Okay.
So because here patients will be more anxious. So we have to manage them first.
Okay. So for basically for the Pecan criteria, what it says like if age is more than 2 years and there are certain points like we need to consider when the GCS is less than 15, presentation is altered mental status, and is there any signs of bacillus skull fracture, anything severe mechanism of injury? Of course, that's a valid point. Vomiting, as you mentioned clearly, raised ICPs, severe headache, and loss of consciousness for more than 5 seconds. If anything is present, definitely this requirement of CT scan is there. All right. So, and the last question for you, what I like to say is, like, what is the target map to maintain cerebral perfusion pressure in case of traumatic brain injury? The target mean arterial pressure you want to maintain, like how much, so that to maintain the cerebral perfusion pressure?
Cerebral perfusion, it should be around 80 to 100.
Okay, more than 90. Basically, we used to
Yeah.
maintain that more than 90 should be there, so that that map and ICP, that should everything should fall in place.
Yes, sir.
So is any signs of raised ICP, anything is there? So initial management is to start with mannitol or 3% saline, what we have discussed. All right. Any more queries from the audience? So it was a wonderful discussion with you, Dr. Madhu Kiran. It was a very illustrative.
Thank you, sir.
And very concise. You have taken your time to discuss 3 beautiful cases. And
Yes,
I think there's no more questions from the panel, like from the attendees. So here I think I would like to conclude and thank you, Dr. Yashoda Group of Management, for giving us the platform to share our knowledge and discuss about this most relevant topic in our day-to-day practice, that is about traumatic brain injury management. Thank you, everyone. Thank you, Dr. Kiran. Thank you so much.
Thank you.